Good afternoon, everyone. And in my last lecture on pneumonia, I described the definition, pathogenesis, the host defense mechanism, the risk factors, clinical features of pneumonia. In this talk, I will continue with how the diagnosis of pneumonia is made and how patients of pneumonia are managed. And I will be covering both community acquired pneumonias, bacterial pneumonias, as well as viral pneumonias. The clinical diagnosis of pneumonia is made by clinical signs and symptoms, which I have described, of abrupt onset of high-grade fever, rusty sputum, and classical clinical signs of decreased air entry, tubular bronchial breathing, and whispering pectoral which is present, and the percussion note which is impaired. The X-ray is a very simple and easy method for diagnosis of pneumonia. And for microbiological testing, we have to test for sputum, for gram staining and AFB staining, and do cultures, and we have to do blood cultures as well. For atypical organisms, serology is very useful, and PCR, of course, is the most accurate method by which we can diagnose pneumonia. And PCR is usually used in viral pneumonias, as in COVID we have the experience. So the lab test in community acquired pneumonia is CBC, and CBC in community acquired pneumonia, there is marked neutrophilic leukocytosis, the total count is increased, the polymorphs are increased, and in addition we have to see for other investigations, oxygen saturation, which is usually done by pulse oximeter, is done, and we have to do KFT, LFT, liver enzymes, the electrolytes, and other investigations are important. So, and ABG analysis, especially for diagnosing ARDS, is important. So in COVID, actually in CBC, what would show in viral pneumonias as such, instead of leukocytosis, what we have is lymphopenia and also eosinopenia. And if the neutrophil lymphocyte ratio, NLR, is more than 3.15, it carries a bad prognosis in COVID. In bacterial infections, of course, we get leukocytosis, which is exactly the opposite. So CBC can definitely help us a clue to differentiate bacterial from viral pneumonias. Chest X-ray in patients who have lobar pneumonia, and I'll show you some X-rays which shows opacification, which may involve the whole lobe, or which is seen in typical lobar pneumonias, or opacification may involve segment or one subsegmental regions, or all over the lungs, which are seen in bronchopneumonia. For COVID, typically it involves the peripheral part of the lung, which is and gives rise to an appearance which is called the reversed bat wing appearance, and also it is seen in the lower lobes. CT scan is, of course, a much more sensitive way of finding out the lung infection in pneumonia, and typical ground glass appearance is seen in COVID, and we always did the CT severity scoring was done to classify COVID in mild, moderate, and severe. CORAD scoring is done. For diagnosis, when and many times it was seen that RT-PCR would be negative and CT scan would show typical features of COVID. In that situation, a CT scan carried is so important, but it's important that CT scan are not done in the first week of fever, because the virus is actually the way to take and 1 week to reach the lower respiratory tract, and the CT scan would be abnormal only in the second week. Inflammatory markers were always done in COVID. We did C-reactive protein and ESR, which was actually acute phase reactants. Ferritin is also an acute phase reactant. Interleukin 6 was sometimes done in more severe cases. For sepsis, we always took the help of the investigation of procalcitonin. Since COVID is a prothrombotic state, D-dimer levels were elevated, LFT, KFT, ECG were also done. But for diagnosis RT-PCR, antigen and antibody tests were done. Antigen tests had a very low sensitivity of 40%, whereas RT-PCR had a sensitivity of 67%. And so a combination of RT-PCR, antigen test, and also CT scan was making a diagnosis, especially in COVID. Antigen test had the advantage that it could be done at home, and the results were available within few minutes, about 15 to 20 minutes. The antibodies took a longer time to develop, and they usually indicated past infection by COVID. So for diagnosis, culture of the sputum and blood is important. So pre-treatment expectorated sputum examination for gram staining and culture can be done, but yield is variable, and many times no organism or contaminated organisms could be grown. Pre-treatment endotracheal aspirate and gram staining can be done. Blood culture yield again is very variable, and if there is a pleural effusion, that can be sent for cultures. Acute phase serologies are particularly important in patients who present with atypical pneumonias and chlamydia and mycoplasma group of organisms. The serologies, the diagnosis is made by serology by doing IgG, IgM, ELISA testing. For influenza testing, we always did the nasopharyngeal swab or a nasal aspirate, and RT-PCR, however, was diagnostic of both influenza as well as for COVID. So how to obtain a nasal? This is the method by which we have to take nasal as well as pharyngeal swab, and a typical X-ray in a patient with pneumonia, lobar pneumonia. On the right side, if you can see, the left side, if you can see, an opacification is there, which is involving one lobe, and this is again showing opacification of lobar pneumonia over here also. And these are the patterns which are very typically seen with COVID. And if you see here, there is opacification over here, and this appearance is basically called reversed bat wing appearance. I'll go to the slideshow. So reverse bat wing appearance, and the infiltrates which we get to the diagnosis, it could be lobar, where it is usually bacterial pneumonias caused by Streptococcus pneumoniae or Haemophilus influenza, Klebsiella, and gram-negative other organisms. If it is patchy, atypical organisms, viral, Nigellina, interstitial again, or cavitatory, and a large effusion. So we can make a diagnosis or a clue by looking at the infiltrates, which could be involving the whole lobe segment or a sub-segment, or it could be widely spread all over in the both lobes, like bronchopneumonia. To admit or not to admit in patients of community acquired bacterial infections, usually we use what is known as the KERP 65, or the other is the PSI, that is pneumonia severity index. Now KERP 65 is one of the various simplest way in which we can categorize patients and for admission in bacterial pneumonias. KERP 65 stands for, C stands for confusion. If confusion is present, we have to give 1 point. And blood urea nitrogen more than 30 mg/%, or respiratory rate more than 30, and blood pressure if it is less than 90 systolic or less than 60 diastolic, and age more than 65 years. So these are the 5 criteria, and if the KERP score is 0 to 1 or 1, patients can be treated at home. If it is if it is 2, a short hospital stay is required. If it is 3, then patient is admitted to a medical ward, and if the KERP score is 4 to 5, the patient needs intensive care management and has to be admitted in the ICU. So pneumonia severity index is again a very complicated, and lot of variables are there. These are mainly used for research purposes. It's very difficult to in clinical practice to implement it. So the criteria for ICU admission is, major criteria is the patient requires ventilatory support. If the patient requires ventilatory, invasive or even non-invasive mechanical ventilation, when the SpO2 has dropped and the PaO2 is less, patient is cyanosis requiring oxygen, and which cannot be managed by simple nasal oxygen. The patient requires ventilatory support, should be admitted to intensive care unit. If the patient develops a hypotension, septic shock, and needs vasopressors, also there is an indication for admission to intensive care. If the patient is confused, has an increasing level of blood urea nitrogen, patient has a higher respiratory rate, tachypneic, patient has severe hypotension, WBC counts, if they are less than 4,000 or platelets less than 1 lakh, platelets less than 1 lakh usually indicates that the patient may have DIC. So basically in the COVID, these were the guidelines, and we classified patients into mild, moderate and severe disease based on the respiratory rate and the level of SpO2. If the patient had no fever, had not breathless, and SpO2 was normal, was more than 94 or equal to 94%, then the patients had mild disease. These patients could be admitted, treated at home. And moderate disease is when the respiratory rate is between 24 to 30 and the SpO2 is between 93 to 90, whereas severe disease is when the respiratory rate is more than 30 and SpO2 is less than 90%. So normal respiratory rate, increase in respiratory rate and decrease in SpO2, we can classify patients into mild, moderate and severe disease in COVID, and the management would depend accordingly. For community acquired, coming back to the treatment of community acquired pneumonia, what antibiotics need to be started in community acquired pneumonia, because it is usually a bacterial infection, and if the patient is healthy, no antibiotics and has not received any antibiotics in the past 3 months, then the patient should be started with macrolide, that is azithromycin, or second choice is doxycycline. But if the patient has comorbidities, is elderly and has got liver and other problems, is diabetic and has malignancy and is immunosuppressed, in that situation antibiotics, has received antibiotics within the last 3 months, you have to start antibiotics immediately, and higher alternate antibiotics need to be started. We can try fluoroquinolones, levofloxacin, 750 milligrams once a day, or a beta-lactam antibiotic like amoxicillin and clavulanic acid can be started. 1.2 injectable doses, 1.2 grams given twice a day or thrice a day depending on severity. This can be combined with macrolide like azithromycin or clarithromycin. The dose of azithromycin is 500 to 750 milligrams once a day, whereas that of claribid is 500 milligrams twice a day. For inpatients who are admitted in the ward, again a combination of fluoroquinolone and beta-lactam plus or macrolides can be given. For patients in intensive care, more higher antibiotics, we have to start with extended spectrum beta-lactamase inhibitors, which includes combination of piperacillin and tazobactam, dose of 4 grams of piperacillin and 500 milligrams of tazobactam given 4 times a day, or ceftriaxone and sulbactam, ceftriaxone 1 gram and sulbactam 500 milligrams given twice or thrice a day, combined with a macrolide. Now, if the patient is allergic to penicillin, then the patient we can use Aztreonam, which is a monobactam antibiotic, which acts selectively against gram-negative bacteria. If the patient has methicillin resistant Staphylococcus aureus infection, which is community acquired, then we need to start with vancomycin 1 gram twice a day, and if there is resistance to vancomycin, that is VRSA, vancomycin resistant Staphylococcus aureus, we need to start with linezolid. So these are the antibiotics we have to start in patients who have community acquired pneumonia, who have typical presentation because of bacterial, and therefore we can also start in more severe cases with carbapenems in patients who are hospitalized, especially patients who have hospital acquired pneumonias. In that situation, carbapenems in seriously infections and pneumonia, we can start with imipenem cilastatin combination of 1 gram TDS, or meropenem 500 milligrams to 1 gram 8 hourly. Doripenem is a newer carbapenem. And if many patients who are extremely ill and who have very severe ventilator associated pneumonias, in that situation we may have to start with much more higher antibiotic called colistin, where the loading dose is 9 mega units, international units, and a maintenance dose is 4.5 to 5.5 mega units given intravenously twice a day. but you should remember that colistin is nephrotoxic, and if there is a renal damage which is possible in patients who have septicemia with multi-organ dysfunction, in that situation the doses of colistin should be adjusted according to the creatinine levels. Polymyxin is again another antibiotics which is similar group, but is less nephrotoxic. So if nephrotoxicity is present, we may have to start with polymyxin. Again, we have to send all cultures for say culture and sensitivity, and which would actually dictate which antibiotics have to be started. There is another newer inhaled tobramycin, which is particularly useful in ventilator associated pneumonia, either in nebulized form or inhaled form. Tobramycin can be tried in ventilator associated pneumonias. In influenza, the antiviral drugs like oseltamivir has to be started within 48 hours of the onset of symptoms, because if it is started late, it won't work. And for the novel H1N1, that is swine flu, the dose of oseltamivir is 75 milligrams twice a day for 5 days. Patients who are hospitalized and patients who have pneumonia, which shows usually a bronchopneumonia type of picture, in that situation, we may have to give a higher dose of 150 milligrams twice a day. Patients who are in contact with these influenza patients may have to give a prophylaxis of oseltamivir 75 milligrams once a day for 10 days as a prophylaxis for prevention of influenza H1N1 pneumonia. So zanamivir is inhaled, it may be used, but that is not commonly available. Now, in influenza viruses, we can categorize the patients into mild category A, B, and C. And mild patients have only sore throat, they have mild fever, and they have cough with or without expectoration, and patients have body ache, headache, diarrhea, vomiting. Since the disease is mild in patients who have very mild grade fever and cough, may or may not have any systemic manifestations. In that situation, patient is treated at home, no lab tests are required, no treatment is required. Whereas if the category B, where the patients have high grade fever associated with severe sore throat and systemic manifestations of body ache and headache, or patient who has mild grade symptoms but it falls into the high risk groups, that means patients have comorbidities. In that situation, we need to start with oseltamivir immediately, but there is no need of doing any lab tests. Category C is category A and B symptoms with when the patients have, in addition to symptoms which are described in category A and B, patients are breathless in addition, and they have become hypoxic, cyanosis is present, and they have chest pain, they become drowsy, they have cyanosed and irritable. In that situation, patients definitely needs hospitalization, sometimes in intensive care unit, and patients have to be monitored and have to be tested and have to be given oseltamivir. So these are again categorized. Category mild disease, where patients have not tested and Tamiflu is not prescribed. For moderate, we have high grade fever where Tamiflu is given but not tested, and category C is when the patients are admitted in intensive care and given and they are tested for H1N1 and they are started with oseltamivir. The test which is done is of course RT-PCR. So response to treatment in community acquired lobar pneumonia, clinical improvement, that is fever becomes less in 48 to 72 hours, though it can take sometimes more longer than that, but usually it settles down in 48 to 72 hours after starting antibiotics. And the signs, that means the chest signs which are classical of lobar pneumonia, may take about 1 week to disappear, but it's important to understand that X-ray will take a much longer time to settle, and patients, it might be 4 to 6 weeks before the X-ray chest is totally cleared. So inadequate response to therapy, patients may sometimes do not respond to treatment, especially in patients who have community acquired pneumonia and then they have, or hospital acquired pneumonias, which are not responding to treatment. We generally say that despite receiving good adequate antibiotics for adequate dose, adequate duration of antibiotics, there is still no response to therapy. that we call that as non-resolving pneumonias, especially when there is no radiological clearing in 6 weeks. This could be because the infection is caused by resistant organisms, or we are dealing with some other organism like tuberculosis, or patients have fungus or pneumocystis carinii. More unusual pathogens like atypical mycobacteria, nocardia, actinomycetes fungi may be responsible for pneumonia, or there could be unrecognized immunosuppression which has to be searched, or there could be a bronchial obstruction which is preventing for secretions to be drained, and non-infectious causes like lung neoplasm, lymphomas and other things have to be ruled out. For this, we need to do more specialized in an invasive testing. For non-resolving pneumonia, we may have to do bronchoscopy and lower respiratory tract sampling, biopsy, bronchiolar lavage, CT chest, percutaneous transthoracic needle biopsy, pulmonary embolism workup, galenium scanning, serological testing, and open lung biopsy. So many patients who do not improve CT scan, and we may have to do a bronchoscopy. Bronchial aspirate is obtained, and that is sent for culture and sensitivity, and bronchoalveolar lavage is done, and we may have to do a biopsy as well. It's important that in addition to antibiotics, all pneumonias will require oxygen, especially if they are desaturating, and also intravenous fluids. Patients who are admitted in intensive care, these and patients who are serious may have developed dehydration and may develop electrolyte imbalance. That needs to be corrected. Intravenous fluids are important. If the SpO2 is dropping, then PaO2 is dropping, then this patient should be put on oxygen. This can be given by nasal cannula which delivers oxygen by 2 to 6 liters per minute, or if that is still not adequate to increase the SpO2 or PaO2, we need to put the patient on a face mask which can deliver oxygen at 6 to 10 liters per minute. And if the patient is still desaturating with this, we may have to put the patient on non-rebreathing mask or bag and mask, and where we can deliver about 10 to 15 liters per minute. We have to target a SpO2 of 94%. And if this patient is still not improving, we may have to put the patient on non-invasive ventilator like BiPAP or CPAP, or before that we can put the patient on high flow nasal cannula oxygenation, where we can deliver about 20 to 60 liters of oxygen per minute. And of course, the patient not responding, we have to put the patient on invasive ventilator. So oxygen therapy is very important. Patients needs to be, PaO2 has to be restored, SpO2 has to be restored more than 90 to 94%. And there is patients who develop ARDS, which is an important complication of pneumonia, and many patients of COVID actually developed ARDS. ARDS is acute respiratory distress syndrome, where we see the P by F ratio, that is PaO2 divided by fractional inspired oxygen. At the PF ratio, if it is less than 300, the patient has ARDS, and this can be classified into mild, moderate and severe. If the P by F ratio, that is PaO2 by FiO2 ratio, if it is between 300 to 200, patient has mild ARDS. If it is between 200 to 100, it is moderate ARDS. If it is less than 100, it is severe ARDS. So we can classify ARDS and severity of ARDS and define ARDS based on this P by F ratio. Another way in which oxygenation can be improved by is giving a prone position to the patient, which may be sometimes very uncomfortable to the patient, but prone ventilation for 16 to 18 hours a day is recommended, which helps in oxygenation. Now let us talk about a few words about ventilator associated pneumonias. And ventilator associated pneumonias are defined as pneumonias that develop more than 48 to 72 hours after endotracheal intubation. It's a nosocomial pneumonia. Now, nosocomial pneumonias or hospital-acquired pneumonias are increasing. They are the second leading cause of nosocomial infection, and not only that, this is a leading cause of nosocomial infection deaths due to. And why it is increasing is because patients who are admitted in intensive care, they have to be ventilated, they are catheterized, lot of central lines are put, and which predispose the patient for infection, and that can lead to ventilatory associated pneumonias and also hospital acquired pneumonias. Similarly, patients who have posterior circulation stroke, which means that the patient has got defective gag and cuff reflex, there is 10th nerve palsy, which allows patients, which predisposes the patient for aspiration, and aspiration pneumonias are common, which are all nosocomial. So, nosocomial infections or pneumonias or hospital acquired pneumonias are increasing because of these reasons. And one of the most dangerous conditions is ventilator associated pneumonia, which is defined as pneumonia which develops more than 48 to 72 hours after endotracheal intubation. That's very important, that patients had no pneumonia, or pneumonia was less when the patient was ventilated, but after ventilation the pneumonia has increased, and that is after 48 hours after the patient is intubated. Now, there are two types of ventilator associated pneumonia: early onset VAP and a late onset VAP. Early onset occurs during the first 4 days of mechanical ventilation, and which is less than 96 hours after mechanical ventilation, and late onset occurs after 48 hours. After 96 hours of mechanical ventilation, that is nearly equal to 5 days or more after mechanical ventilation, after endotracheal intubation. Mostly it is in early onset VAP is caused by bacteria which are sensitive to antibiotics, and patients' prognosis comparatively better, and they cause a less severe pneumonias and have a better prognosis. But late onset VAPs are more dangerous, because when late onset VAPs, which occur after 98 hours after mechanical ventilation, they cause multi-drug resistant pathogens are responsible and associated with increased morbidity and mortality. Now, etiology mainly of VAP, which occurs after 96 hours of endotracheal intubation, are these gram-negative bacilli like Pseudomonas aeruginosa, Klebsiella pneumonia. Acinetobacter baumannii is a very dangerous organism, which is a very classical in ventilator-associated pneumonias, hospital-acquired pneumonias, hospital-acquired infections, E. coli, and then we have Staphylococcus aureus, particularly MRSA organisms. Fungal and viral infections are distinctly uncommon. 40% of these infections have got multiple organisms. And then the drugs which I have said, we can use more higher antibiotics, tazobactam, piperacillin, tazobactam combinations, or in patients who have MRSA, we may have to use vancomycin, and VRSA, we may have to use linezolid, and or carbapenems are commonly used. And colistin is the last choice, and we may have to use many times colistin, which acts against Enterobacteriaceae, and as in ventilator associated pneumonia. High dose of colistin and ampicillin sulbactam have a comparable safety and effectiveness for treatment of critically ill patients with Acinetobacter baumannii infections, VAP. So, this is an important drug which we have for VAP. Now, prevention is very important. For prevention of pneumonia, we ask the patients to stop smoking, give a good nutritious diet, and vaccinations as per the recommendations have to be given. For influenza vaccine, as advocated, we have a quadrupole inactivated vaccine which has to be given to people for more than 50 years of age, and those at risk for influenza complications, and all high risk persons and healthcare workers should take annual influenza vaccine. Now, this vaccine has to be taken, one injection vaccine has to be taken every year. Why this is so is because influenza is a RNA virus, and all RNA viruses actually they mutate very easily, and new form, there is a new type of virus is formed every year, and because of this the vaccine against that virus is influenza virus, that strain is prepared, and therefore we have to take the vaccine every year, especially after the age of 50 years, or in those who have comorbidity or those who are healthcare workers. There is also an intranasal live attenuated vaccine which is given to children from between the age group of 5 to 49 years, but this is not usually preferred. Then another vaccine which for bacterial pneumonias we have pneumococcal vaccine, and this pneumococcal vaccine is given to after the is recommended for all immunocompetent persons more than 65 years, and in those who are immunosuppressed even less than 64 years they have to be given. So pneumococcal vaccine, H influenza vaccine, and influenza vaccine has to be taken. Similarly, now we have COVID vaccines available. We have the Covishield and the Covaxin available in India, and 3 doses. And we have already taken the first dose, majority of us, the booster dose, and then the precautionary dose. So has to be taken. And COVID vaccine is again another type of antiviral vaccine which has been tried. But it is very important that influenza and COVID, the precautionary and measures and preventions are very important. So patients have to wash your hands. We have to, if they are feeling ill, we have to stay home, and we have to cover the nose while sneezing or coughing, and we have to don't let the flu slow you down, get vaccinated. So cough etiquettes is very important both in patients who have pneumonia, especially those who have COVID and those who have influenza vaccine. We have to cover the nose while sneezing, and another method is just coughing over the arms bent, and this cough hygiene is very important. And then masking is another very important thing. This is COVID appropriate behavior, taking cough etiquettes and covering your mouth and nose with a mask. Usually a triple layer mask is sufficient, or we may have sometimes in more severe infections if we are going, we may have to require not only a surgical mask but also N95 masks maybe have to be used. Hand washing is very important for common people, and there is a particular technique by which hand washing has to be done, and this includes at least for 20 minutes, 20 seconds hand washing has to be done, and this is the perfect method by which hand washing has to be done. So which has to be done for at least 20 seconds. And this is another detailed illustration of how hand washing is not a question of just washing your hands, but washing them properly in a properly prescribed method, which is very important. Another, we have to keep safe distance, avoid close contact, maintain a distance of at least 1 meter to 2 meters, avoid contact with people who are sick, and maintain safe distance. So 3 very important precautions. We have to wearing a mask, cough etiquettes, washing your hands, and maintaining safe distance is very important in patients who have especially viral pneumonias like influenza and COVID. Contact precautions like using a PPE medical mask, the eye protection, gloves, gown while entering and leaving the room. It's very important where going into the wards, we have to wear this personal protection equipment. Is very important to prevent infections. So just to summarize, in community acquired pneumonias, we may have to use early antibiotics which have to be administered 4 to 6 hours after the diagnosis is made. And it's very important that we start with empiric antibiotics, especially in bacterial pneumonias, because if we don't start and bacterial antibiotics at an early stage can given for adequate dose for adequate time, complications could occur. And I've just gone through all the antibiotics which have to be given. Depending on the setting, we can predict the most likely organism. If the patient has developed community acquired pneumonia in the community, in that situation, the most likely, and when the presentation is very typical, in that situation, the most likely organism is either Haemophilus influenza or Streptococcus pneumoniae, or it could be, if there is atypical presentation, they could have chlamydia or mycoplasma organisms which are responsible for, and we have to start antibiotics accordingly. If it is a hospital acquired pneumonia, then we may have to think of more dangerous gram-negative organisms like Pseudomonas and Klebsiella, where we need to start with higher antibiotics. If it is a suppurative pneumonias, patients who have staphylococcus infection or Klebsiella pneumonias, adequate doses have to be given for adequate antibiotics, have to be given for adequate time, otherwise it could lead to lung abscess as a complication. And we have to then follow the CURB 65 guidelines for whether the patients of pneumonia can be admitted in hospital or treated at home, and if the CURB score is high, we may have to admit not only in the ward but in the intensive care. And early hospitalization, smoking cessation, arterial oxygenation, blood culture collection before the antibiotic therapy is all very important. IV fluids have to be started, oxygen has to be started in order to maintain the SpO2 more than 94%. Otherwise, the patient would collapse. Pneumococcal influenza vaccination is very important, and in order to prevent pneumonia. And I have gone through all the risk factors and comorbidities and high risk groups, especially the high risk groups include the elderly more than 65 years of age, patients who have heart disease, who have lung disease like COPD, asthma, or patients have mucoviscidosis, or patients who have liver disease like cirrhosis of liver, or patients who have chronic kidney disease. These are some conditions where, or patients who are immunosuppressed, that means patients who have low immunity because they are on steroids, or they have malignancy, or they are on chemotherapeutic agents. In that situation, the patients have to be treated with more vigorously and more accurately, because this mortality is high in patients who have pneumonia due with comorbidities which they are present. So influenza H1N1, I'll just go through it, that it is a RNA virus. I've told you type 1A and B. A is responsible for epidemics and pandemics. B may cause milder epidemics, but C type is actually does not cause any significant disease. And influenza virus or H1N1, which was caused by RNA vixovirus. And H1, what does H stand for? H stands for hemagglutinin, and there are 16 types, H1 to 16. Neuraminidase stands for, N stands for neuraminidase, and the N1 to 9, there are variants. So we have a lot of variations. H1, N1, we could have H5 and 3, all sorts of variations are there. They are two surface antigens. These are 16 H antigens and 9 N antigens. Different combinations can occur. And antigenic shift and antigenic drift is very important, because the virus actually changes its structure. Major antigenic variations are called antigenic shifts, and which are associated with pandemics, and minor variations are called antigenic drifts, and hence annual flu vaccine is advised. Similarly, for COVID, we found that it is also an RNA virus, where we also found that there were 3 waves. The COVID in fact started in early 2020s, when in the month of March, and with the lockdown was imposed in 2020, which was lifted on 31st of May. The purpose of lockdown was that we improved our infrastructure, oxygen facilities, ICU beds. We also improved our PPE kits, N95 mask production, and in a record time we were prepared for when the lockdown was lifted. The cases started increasing, and in the first wave the maximum cases were about 1 lakh per day, and which was in September. And then this was then followed by a second wave, which was caused by Delta virus, which was again a mutant virus of COVID, which caused a lot of devastation and a lot of misery. People did not get beds at that time, and finding oxygen beds and intensive care beds was difficult at that time, but fortunately we came out of it. The third wave was because of Omicron, and Omicron actually caused a mild disease. And one of the most important features of the COVID response was that in the lockdown we actually we prepared ourselves for the pandemic, and most importantly, we could develop an indigenous vaccine against COVID. We had Covaxin, which was prepared indigenously by biotech, and we were we could do mass vaccination of majority of our population, which caused, and hence the subsequent waves did not affect people because vaccination provided some amount of immunity. So this is all I have from here. Thank you very much for a patient listening. Thank you very much.